This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
We've been talking about the future of ambulatory care for a long time and focusing on care outside of the four walls of the hospital. None of that is new. What we're talking about here is why haven't we made great progress as legacy health systems towards achieving that vision?
Welcome to SG2 Perspectives. I'm your host, Trevor DaRin, and I have my two friends and colleagues, Tori, Richie, and Tony Guth here to talk about some of the new research they've been doing in the idea of an ambulatory first mindset for health systems. I'll just let Tony and Tori explain what this framing means. Tony, what does ambulatory first mean? And even more important than us just coining a new term, why does it matter?
Trevor, I think this is our term that hopefully picks up. When we think of an ambulatory first organization, it's one whose ambulatory services are the primary driver of financial, operational, and market success. This means the hospital is not the anchor of your health system anymore. It means that ambulatory services don't simply feed your hospital. This means that our reliance on fee-for-service is gone, and we can focus on true population health with amazing access to care for our patients. This is flipping a mindset from one that's hospital-centric to one that is a true integrated delivery platform that can ultimately defend itself from creative, nimbler disruptors that are out there taking a lot of our business. Most of SG2 members are traditional health systems, and all of them who want to succeed has to figure out how to get past some long-standing business orthodoxies to finally transform into an ambulatory first organization.
Tori, how would an organization look any different if they were truly ambulatory first? How would you know by talking to a health system, working with them? How would you know if you're looking at a competitor in the market if they're more ambulatory first than you are as a health system?
We've talked with a handful of organizations that have embarked on this work in terms of scaling and reprioritizing their lengthy list of strategic initiatives to ensure that they're placing more emphasis on that ambulatory environment. What we found is, number one, from a financial perspective, we need to be carving out a capital allotment for ambulatory projects. We need to be able to also split out ambulatory activities on our budget sheet, making sure that there is distinct profit and loss for those ambulatory activities so that we're able to determine how successful are we in this arena? Are we achieving our end goal of being financially viable and sustainable in those ambulatory initiatives? That's a big part from a financial and capital deployment perspective, starting to get specific and carving out those ambulatory details. Org structure is another big one. For so long, ambulatory fell under the individual service line lead. So there'd be a cardiovascular service line team that would then be responsible for the acute and the ambulatory side of the house. But what we're seeing in really innovative healthcare systems, starting to actually separate ambulatory operations and have leadership that then reports through the C-suite. So that is then ensuring that ambulatory side of the business is receiving the attention, is receiving the support, is receiving the staffing that's required to be successful.
I want to hear more about the org structure that we think is going to work best here. I was talking about this with a member and they said, should the ambulatory leader be equal to like a hospital president? And then it's the ambulatory operational leader versus the hospital presidents, who the ambulatory leaders incented to grow ambulatory and the hospital leaders are incented to grow their individual hospitals. That's like the easy default for us. And then they cleared it out because they're a strategic leader and thinker and said, I can see that end point. That's probably not what we're shooting for. So what org structure do you think is ideal here?
In the organizations that are the innovators in this space, that is the reality, is ambulatory is equal to the acute care side of the house. They report through the same C-suite individual and they are seen as equals. It's not a tiered approach. They have to work together. They have to work in very close collaboration to ensure that resources are being efficiently and optimally distributed across those different sites of care, but they are equals.
What we're trying to get across with the org chart, talking about governance and leadership for ambulatory, the whole point is to elevate some kind of ambulatory champion so that when we are talking about capital allocation every year, every quarter, however often it's done, these ambulatory projects actually have a chance to get prioritized because it's way easier to look at and prioritize a new OR or a new bed tower. It's just the ROI is easier to calculate for that. pretty simple math, especially if we're in a fee-for-service world. But it's way harder to figure out downstream cost savings and population health benefits for like investing in a primary care clinic or some new ambulatory investment that's just got a difficult ROI to prove. It's about elevating ambulatory with a champion that's on par with hospital services.
I've never been mistaken for a CFO before, but I'm going to pretend for the next moment to be CFO Trevor. This is a fun idea, guys. We make more money in our current structure of patients coming through our ED and being treated inpatient when it's appropriate. And why are you forcing me to push them to a setting where I don't make margin today? Maybe there's an SG2 forecast that's part of that answer, but why would health systems try to beat the market there rather than wait until maybe it's mandated from a regulatory or payer perspective?
That's just it, CFO Trevor. We're starting to see that payer pressure. We're starting to see those downward pressures that are forcing traditional health systems to think about how they need to deliver care in a different way. First and foremost, we have Medicare Advantage payers, if nothing else, that are really starting to scrutinize where and how patients are being treated. And as we see increasing scrutiny, increasing denials, increasing requirements for prior auth on the MA side, it's only a matter of time before that starts to trickle to the commercial side of the house, which is where margin is being generated for most health systems. And so instead of operating in this reactive mindset of this is the way that I've always done things and things haven't broken for me yet, we encourage organizations to be proactive and make the change while you still have control, while you still have some nimbleness afforded to you. Number one, it's only a matter of time before your hand is forced here. And number two, it's a lot easier to scale on the ambulatory side than it is on the inpatient side. And you mentioned the forecast. If we think about some of the trends that are coming out of the impact of change, we're continuing to see higher levels of patient acuity. The patients that we're treating are getting more and more complex. We're contending with the aging population, which is going to continue for decades to come. It's going to be more and more challenging to manage patients if we're relying on ED and inpatient sites, because we just simply do not have the physical space to continue that blocking and tackling. We need to, again, be thinking about prevention, reducing onset of disease, preventing the exacerbation of disease, and all of that's going to be done in that ambulatory side of the house.
You nailed it, Tori. To CFO Trevor, I would say, can you even fit these patients that you're supposedly making money on? And I would challenge you on that, by the way. Like, not every health system, not every hospital is making money, making margin. Well, then I would challenge you to think about who's actually bringing the margin in your hospital. Because 79% of the patients likely in your hospital are what we would categorize as low and medium CMI patients that are mostly medical admissions. You're probably not making a margin on those. Are you going to be a contrarian and build a new tower when maybe you don't need one and fill it with 79% medical patients? It's not exactly what the future of healthcare looks like, we think. So capacity is a big piece of it. And making sure that we're filling our beds with patients that belong in a hospital, it's a real challenge to do that correctly. The vast majority of volume is outpatient. And that's where all the money is. You can say what you want about private equity, but they're investing mostly in ambulatory services. So if there's money to be made there, you can pay attention to what they're investing in and what these smaller upstarts are doing. This is where the future is. And as volume continues to grow there and to leave your hospital, you want to skate to where the puck is.
And the practicality of continuing to rely on an acute care strategy, it gets harder and harder to execute as time goes on. If nothing else, if you think about workforce, the type of staff that you need to have in order to manage that incredibly complex inpatient population, you're talking more about doctors, specialists, highly skilled individuals that are pretty rapidly aging out of the workforce. And we don't have the requisite number of physicians that are backfilling those individuals. And so if we think then about scaling on the ambulatory side, we can more effectively deploy our APPs, our nurses, our aides, our techs to be managing patients whenever possible in the ambulatory side of things, reserving that physician capacity for the patients that are most complex and need to tap into that level of expertise.
Tony, last week we got to hear a bunch of strategy leaders talking about the ambulatory first approach through our strategy exchange. In the group I was facilitating, I really didn't have to sell this to anyone. They totally got it, but they're strategy leaders. They're not operational leaders. They're not incented to grow an individual hospital's volumes, and they're not financial leaders. What were some of the takeaways you had? We did a survey and got a bunch of quantifiable answers from folks about how they're moving towards ambulatory first, or something interesting you heard from your breakout group there.
First, to your point about your group not having to be sold on this, like that makes sense. Like we've been talking about the future of ambulatory care for a long time and focusing on care outside of the four walls of the hospital. None of that is new. What we're talking about here is like, why haven't we made great progress as legacy health systems towards achieving that vision? And it is because of those orthodoxies that Tori was walking through earlier. The way we allocate capital, the way that we bias easy ROI decisions, the way that our governance structure is built up, the way that our workforce is deployed, and the way that our ambulatory business unit doesn't have its own P&L. These are business-changing things that are hard to upturn. It's one thing to talk about the future of healthcare and to have an ambulatory lens on it, but the reason why we're not going in that direction is because of these business orthodoxies. So with that said, the one thing that we talked about in my group was one of the survey results. Only 30% of the participants were from health systems that had clear, fully dedicated leadership for ambulatory services at the system level. It makes it difficult to prioritize ambulatory if we don't have a champion. And an ambulatory champion whose seniority is elevated to hospital leadership will ensure better odds that ambulatory projects are better represented in capital planning discussions, for example. Another takeaway was that a handful of members said in the survey that they had no capital for any projects. So it's not that they aren't doing ambulatory growth stuff because they've prioritized something else, like some hospital project. It's that they can't afford to do either. They're just trying to keep the lights on. And that's another reality we have to deal with. A lot of our members are bogged down in daily operations and need real help in figuring out strategy.
Tony, to that end, that's where with the ambulatory first work, so much of the conversation that we've had has really been breaking down the silos that exist across those different business units that you talked through and gaining alignment across operations, finance, strategy to ensure that we're all on the same page and aligned on how we should be investing in which areas of the business. When I think about how we have been talking about ambulatory strategy for the decade that I've been at SG2, we really haven't seen organizations move the needle much. And my assumption, and this might be a faulty assumption, is the reason why we haven't seen much achievement in this space is because we are continuing to operate in those functional silos. Strategy might have this great idea for how we want to expand ambulatory, but because the other organizational structures aren't in place to execute, that strategic plan just gets left in a pamphlet that's stuck in a drawer somewhere for years and years to come.
Or like you mentioned before, it's run through a traditional service line planning process and they're balancing it against tried and true existing sites of care, patterns that they know and trust. The endpoint you're talking about here can seem pretty different than where we are today, a daunting pivot. What are some milestones or steps along the way that you look for in an organization to know they're kind of moving? Or said another way, if I'm a strategy leader, what can I try to put in place to help us get from point A to point B?
So what are the baby steps? Tony, curious on your thoughts, but in my mind, I don't think that you're going to get anywhere unless you start with how the organization is structured to ensure that you have clear ownership and responsibilities for those ambulatory leaders, but they also then have clear communication channels that allow them to work across the other business units. It seems like that's the first step. And from there, you begin carving out financial and capital resources that allow you to start chipping away at some of this innovation, at some of this investment that we've talked about.
And some of the stuff we recommend in our research and our publication we're writing it's going to be pretty hard to do. We're recommending trying to create an ambulatory business unit with a P&L that has like overhead spread fairly. That's really hard to do. There's a reason why overhead is spread from our hospital business across outpatient ambulatory sites. So to do it any differently would be a heavy lift. So the first step is a baby step approach. For example, let's maybe come up with some kind of defensible way of allocating costs for like IT or HR or something to ambulatory services so that we can get maybe a real understanding of revenues and costs for these services that typically get buried in the way we currently do accounting. Some kind of baby step guesstimation is the first thing we would do. This isn't like flipping a switch. So each one of our recommendations in challenging these business orthodoxies is like a sequenced approach. This isn't going to be a 1-year thing. This is going to be a changing of how we do business as a health system. That's what we're trying to get at here. And that's our hypothesis, is that the reason why we haven't achieved this vision of ambulatory care, of what the health system should be to keep people healthy, to keep them receiving care in the right place at the right time, is because we've got these orthodoxies in our way. And it's not going to flip overnight. A lot of scenario planning, a lot of baby steps, a lot of phased in work is what's going to be needed to get this done.
I would be looking for a system whose leadership was synced up on when we see a growth opportunity, when we plan for next year. We need to be pretty focused on ambulatory is the first way that we think about that, almost like a big network and streaming. No, it's not two things happening. It's like, no, streaming is the business. It wasn't just kind of a little sidecar. And I feel like I've heard some CEOs talk that way, but I haven't quite seen it trickle down to like the next layer and it's really put into practice. So that's what I'd be looking for. Do you think next year we'll be having the same conversation and saying, ambulatory first, we really got to get there. I'm looking forward to seeing some first steps and early movers. How are you going to know that we as an industry have turned the ship?
It's a big ship to turn. So I think we will be having, unfortunately, the same conversation next year. The optimist in me is saying maybe we have taken those initial baby steps. Maybe we do have more organizations that, if our survey was to be taken at face value, more than 30% of the health systems will have some kind of fully realized ambulatory leader reporting to the CEO in the same way that others do. That's a good sign. Another sign is maybe we're taking some first steps to develop an ambulatory business unit with its own P&L statement so it can stand on its own. It's going to be on its way to not just feeding the hospital, but being its own reliable, profitable, growing business unit. Next year, it'll be nice to see these initial steps happen. Some are going to be easier than others, but it'll be nice to see it going that way.
The easiest metric that I'm thinking about is how many phone calls in the next year am I going to field on the need to grow inpatient beds? If I start to see a decrease in those number of queries versus then how do I get my house in order to scale on the ambulatory side, just even anecdotally starting to see the needle move in that direction is a good indicator that we're growing that early adopter bucket.
That's a great one. Love it. This is such an interesting topic. And hopefully we will still be talking about it next year, but we'll have some signs of progress. Tori, Tony, thank you as always for sharing your wisdom and your perspective with our listeners.
Thanks, Trevor.
Thanks.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.